Thank you very much, Dr. Woods, and then
Great.
Member Waldron.
Great. Thank you very much. I just want to echo some of the comments that Mr. Vigil made. I think it's really important that we do have an accurate measure of the adequacy of our network. I don't believe that the network, I don't think we have the data. As I said, I'm still listed as a provider. I haven't provided services for a year and a half. So who knows what our provider network is really right now. And also, it's not just about a network that just provides, where you've said, well, you've provided one Medi-Cal service for the year. We kind of need to know more than that. I mean, one service is not a provider, for a year. We need different metrics there, because I think you're going to find that the network is much smaller than that number that's on the books actually shows. And that just shows how much, I think if you don't have that base information, you don't know where you are in the process, it's pretty hard to look at strategies for how do you build upon that. I also agree that the virtual dental home will be a really valuable tool, and I encourage people to support that as well. With regards to managed care, honestly, it's been a disaster in Sacramento. I mean, there's no other way to put it. When you have people going outside of the managed care to a fee-for-service program, completely avoiding the system, it's a disaster. So we need to get around that. And LA isn't much better. And evidence of the disaster in Sacramento is only to look at the maps that came up with the state auditor. It shows clearly that we're not serving the population. So all 5 counties that I represent are underserved counties up there. And one of those stuck out like a sore thumb because it has 0 providers that can accept new patients as children. So I want to, and Myra, I completely agree with you that we need to be thinking outside the box. We had years ago, we had programs in schools that were great programs, dental disease prevention programs, opportunities to educate kids in schools. Now, that was sacrificed as a line item in a budget a governor ago, and I think it's really unfortunate. And so those kinds of things, that short-sightedness, that line item in a budget, leads to big implications later on. We saw that when we cut adult dental, and we warned people that, this is going to increase in emergency room visits, and guess what? It did. So I'd love to see the numbers on that and see, did we really, really accomplish anything? And then finally, as far as sedation services and around managed care, and I don't know, Dr. Blake may be able to chime in on this if he chooses to or not, but we have a surgery center in our county that actually has served now well over 10,000 children. And I will tell you that getting authorization is really, really difficult for that. And these are kids that are 3 and 4 years old with 7, 8, 10 cavities sometimes. These are kids that can't be treated in traditional dental settings. It's just not possible to do. They're very, very expensive to treat. And we shouldn't have to get to that point. So that's why those thinking out of the box on these preventive measures. But when we have those cases, we've got to find a way to treat them. And in some of the managed care plans, certainly I know anecdotally in our area and then in the Central Valley, these cases are routinely denied from the very beginning. So you have to fight, and you're putting these kids at risk for infections. And so we've got to draw the line somewhere and say, no, we can't do that anymore. That's unacceptable. Otherwise, we will have a child die. And it's really unfortunate. So I thank you very much for your comments.
Member Waldron, and then Senator Monty.
Thank you, Mr. Chair. Just briefly to Ms. Kinney, as a mom, it breaks my heart to hear of parents trying to get their kids in who seriously have an issue and they can't be seen. And I would say, you probably see that more often than not. And, in the general realm of dentistry, if someone calls, as a Medi-Cal provider, how long does it take to get in if you are able to see them? Or, how many are being turned away? And then that goes to the case that, Mr. Woods was just saying, Dr. Woods, about how much is that going to cost in the long run? How much pain and suffering is there? So when we talk about assessing network adequacy, I can say, even from a mom's point of view, if you're being turned away and you can't get your child care, then the adequacy is definitely failing. So, thank you.
Senator.
Thank you. I want to thank the co-chairs for convening this and all of you for being here today. The auditor's report, Table 5, shows this huge disparity between national averages and Medi-Cal, Denti-Cal reimbursement, sometimes as high as 10 to 1, 3 to 1, 4 to 1. Does a 10% increase in these rates make a difference? Is it going to change at all the current crisis that we face?
I'll start with that. You may want to chime in too. No, that'll just bring us back to where we were in 2013, which was struggling. And so it's a start. It's help when you work on such thin margins. 10% is great, but does it solve the problem? No, it doesn't even come close to it. So.
And a restoration of the 10% actually takes us back to 2002 rates. So unless there's a cost of living increase from 2002 to the present, we're still not within a reasonable rate.
And I think, as Assemblymember Wood raised as well, I think one of the shortcomings of our budgeting practice here is not to look at out-year costs when we don't adequately fund, particularly in the area of prevention, whether it's dental care or health care. I don't think we have good data on the increase in emergency room visits, the increased cost to the taxpayer when we don't effectively fund at the front end. And that's an economic analysis. The other analysis that doesn't come through the numbers is the quality of life, particularly for young people who are destined then to a life of complex dental management. And you know better than I what those trajectories are. I guess just to conclude, as part of prevention, what do you see being the impact of diet, nutrition, sugar-sweetened beverages in children's diets, and do pediatric dentists include any counseling in that area for any of you?
Huge impact, but I'm going to defer to First Five that we've worked with before on that very subject. They're probably the best at promoting a lot of a preventative.
Well, I appreciate your comments. Exactly. Obviously, educating folks around parents around the importance of nutrition and staying away from sugar-sweetened beverages is a critical part of building that comprehensive landscape for families so that we are educating them at every place along the way, from the newborn home visit through preschool, so that those families are getting those messages from every provider, but certainly the pediatric dentists and the pediatricians are carrying that message very loud and clear for us. But that was where, in many ways, our First Five investments started 15, 18 years ago around oral health, was simply beginning with the parent education, because we did not yet know at that time when we started how much bricks and mortar investments we were going to have to make. But certainly First Five sees itself as needing to work with all child care, health care providers to ensure that parents get that message. Agree, absolutely.
Thank you. You've been great champions in that area, but again, it's something the numbers don't reflect. When you don't have the access at the front end to just that basic consultation with a family, it's not even a procedure that's reflected other than a newly established patient. Maybe there's some more of that engagement of family history and patterns of diet and nutrition, etc. But again, I'm particularly looking forward to hearing from our friends with Department of Healthcare Services, because I think the questions have been framed and we are in need of answers. So again, thank you for your contribution today. Much appreciated.
Thank you very much, Senator. We'll have the last final comment before we transition by Mr. Ridley Thomas.
Yes, thank you, Mr. Chairman, and to our co-chairs. This is a rather important dialogue, and thank the State Auditor for a comprehensive report. More of a comment than a question. Feel free to respond with the Chairman's indulgence. I have a bill this year, AB 880, that looks at scope of practice with respect to fourth-year dental students and those large clinics that we have all throughout the state. We're pretty large in Long Beach and Los Angeles, and we've seen overwhelming numbers of folks who are there seeking dental care. Even with the providers that volunteer their time, we just don't have enough that can serve the dental needs of the greater Los Angeles area. And, you know, it's even more than greater Los Angeles. Many on this committee will know that folks come from all over Southern California, as far as the Inland Empire and the Southern Central Valley and San Diego County. When any of those large health clinics, there are a number of different names for them, the Association of Free Clinics, the March Life Clinics, the and the like. I think it's a way to get at some of the issues. It's clawing at the edges, but it may be, in terms of critical care today, it may be a part of the dialogue, thoughts or opinions on proposals like that one and others that you worked on previously. Welcome the dialogue with the Chair's indulgence.
Anyone would like to comment on that before we transition?
I think that being able to provide care in those types of situations has been a benefit, and any opportunity that we have to participate in those, we are willing to do so. I think that it also allows for those senior dental students to be exposed to a different delivery or a different population to deliver care to, and hopefully inspire some of them to actually go to those communities to provide care.
Thanks so much, Mr. Chairman.
I'd like to thank this panel for providing testimonies to this body. We're going to ask you to please have a seat in the audience just in case we need to call you back up for any questions and clarifications. We'd like to invite the Department of Health Care Services to please join us at the table. Ms. Kent, the Director, and also Kent Well, the Chief Deputy Director of Health Care Programs. Welcome.
Good afternoon.
Good afternoon.
So Jennifer Kent, Director for the Department of Healthcare Services, and thank you for the hearing today. I want to say first and right out front is I have heard you. When I took this job about 6 weeks ago, I had a list of things that I knew the department had, confronting it in terms of significant challenges and or hot issues. And this audit, when it was made public, I knew that this was going to be something that the legislature was going to obviously want a response from us. And to the extent that it has identified issues within the DentaCal program, those that have worked with me in the past know that when I say that I'm going to put my shoulder to the wheel and get some results and figure out what a solution to the problem is, I'm usually pretty good at doing that. So with that, I want to say that the audit was fair, and they identified a lot of both weaknesses and issues that had gone long untended in the program, and so that is why the department agreed with the findings in the report. It is a $1 billion program, or almost $1 billion program if you look at the last estimate. And I think it's also a fair question that the legislature ask us, if we're spending $1 billion in today's program, what are the results that we're getting? How are we measuring either success, or how are we addressing the challenges? And so for that, I wanted to just kind of acknowledge first and right off the bat that we have heard you. For some of the things that are ongoing as a result of the audit, I wanted to acknowledge that we have several different kinds of monitoring and access reports that we have underway, both as a requirement from the federal government as a term and condition for the AB 97 provider payment reductions. They had separate and distinct monitoring and access standards that they had us agree to as a way of approving our state plan amendment. And so that is one aspect that we are monitoring now. There are also I think 11 standards that we are monitoring too that were the result of legislation, I believe. Maybe was it from Dr. Pan's legislation? There's 11 monitoring standards that we are now doing on an annual basis, and as part of the annual report that we have, there are quarterly reports that we are receiving internally. I know that transparency is both important for you as an oversight body, as well as for us to understand what's happening in the program down on a more granular level. And so we have done provider dashboards in Medi-Cal managed care. Those are public. They're issued on a quarterly basis. They both track both financial quality and access standards for our Medi-Cal managed care plans. We are moving rapidly to do something similar in dental, in DentaCal. And again, dashboards are a little bit of a complicated endeavor. They take a couple of they take several people actually to do the IT and the data work in order to get those up and running. So we have something that we are working on internally now to see that it's giving us the kind of information that we think is appropriate to make sure it's valid and accurate. And then we hope to make those externally facing because, again, in the interest of transparency and having individuals know that we are trying to move the needle forward, that's something that we're working on. We have taken proactive steps to work with our vendor. I know that we have a fiscal intermediary that handles the claims and provider reimbursements for us today. We have sat down with that vendor and said that, things are obviously needing improvement. Part of the audit response with the corrective action plan was that we have steps that we've taken with them to address some access issues in counties in which there are no providers. So we have mobile vans that are in Amador, Alpine, and Calaveras. We expect that there will be additional outreach services. We have done a beneficiary mailing that went out last month. We don't know what the results of that beneficiary mailing are to date because it's too soon to tell, but we can tell you that call volume has increased in the call center by about 250 calls a month, a day. So we know that is having some impact. We also did a provider survey, and so to Dr. Wood's comments about, what are providers on an individual basis in certain geographic areas doing? We conducted a survey back in November and December and essentially had 22 questions that we asked providers in terms of, are you taking Medi-Cal patients? If you were to take Medi-Cal patients, how many would you take? If you're not taking them, is it due to reimbursement? Is it due to administrative, burdens? Is it due to other things? And so those are data results that we are compiling. We will be making those public. I know that data overall is important for all of us and how we do things. And so I know the rate study has also been a significant concern with the legislature. And so we, I think, had said that we were going to be turning a rate is down in July, and so that is different than the AB 97 report. So I think that is also something that we are committed to providing, and obviously that is maybe too late to be a part of this year's budget, but we also acknowledge that to the extent that the rate comes out, or the rate study comes out in July, that would be something that we could either have a conversation with you, the legislature, and/or others and stakeholders. It could potentially impact the November estimate, which is what we provide as a means of the governor's January budget. So, lastly, the waiver, and Mary can speak to this as well, is that we are embarking on a new 1115 Medicaid waiver, and I don't know for how many individuals that have tracked this issue with the department. Is every 5 years we go to the federal government and we seek a significant number of federal dollars to do things that we otherwise would not be able to do, either because of CMS rules or other things. And so one of the components in our waiver that we have identified is actually working to identify additional dental providers and to either pay them an incentive to take additional Medi-Cal patients, or if their practice is actually closed to Denti-Cal at all, could we get them to open up their practice? And we recognize that is, in some cases, a way to bring new providers in. And so with that, I don't know if Mary has anything she wants to add, and if not, we're open for questions.
Thank you very much. I don't know, you've been in your position for 6 weeks?
Week 6.
6 weeks.
It's fantastic.
I don't know whether to say congratulations or condolences.
I will take both.
Okay. You made mention that the call center is 250 calls per day. Can you give us an example of some of those calls that are been coming in?
Sure. So the call center is there to provide, Mary Cantwell, sorry, Department of Healthcare Services. The call center is there to respond to any types of inquiries that might come from beneficiaries as well as sometimes providers. And so we can certainly get the breakdown of what the different types of calls we're getting, but we get calls about, I I need to find a dentist. How do I find a dentist? I'm having trouble getting an appointment. And our contractor then is supposed to work with that caller to find the answer to the question or direct them to a provider who can see them.
Great. Ms. Kent, you said if I heard you correctly, so you said that you agree with the auditor's report. Was that correct?
Yeah.
Does that also mean that you agree with all the recommendations that she's put forth?
Well,
And if not, if you can please clarify and give rationale to that.
You know, the department agreed with 23 out of 24 of the audit's recommendations.
So
I think
there's
on
one that you don't agree with.
on the 24th recommendation, and I would say, you know, I looked over both the report and our responses. There's a proxy ratio that we use in managed care, which is 1 to 2,000 providers, and that is set up through the Knox-Keene. There's all the dental managed care plans are required to follow that. In fee-for-service, we're not quite sure what that ratio can or should be. It doesn't necessarily have an equivalent ratio, and so to the extent that there's not something that's set forth, I mean, so for example, in Medi-Cal fee-for-service on just a Medi-Cal basis, those ratios don't exist either. And so really what you have us not agreeing with is not necessarily that we don't think it's an appropriate recommendation. It's more that we're not quite sure what that ratio could or should look like. And so to the extent that there are either ideas or peer-reviewed journal articles or academic literature or something that would say in other states, we look to other state Medicaid programs for good practice patterns as well. If there's a ratio out there in a fee-for-service environment for dental care, we would love to take a look at it. But I think that was the basis for the recommendation. It wasn't that we disagreed that it was inappropriate. It was that we just don't know what that ratio is.
Thank you very much. Do you think that there is room to improve the utilization rate? And if so, you can please explain?
Yep. So we, we're California, so we're kind of big, and in the Medicaid programs in the rest of the country, we tend to look at these small states and say, whatever, LA's got more, Medi-Cal members than the entire other state's population combined. We looked at the other large state dental participation rates for children, and we know that we could do better, but we also know that other states with different rates and other different provider types in place are somewhere in that general 45 to 52% area. And so, I think that none of us are happy that that number is the number, but I think it's also, as everything is in Medi-Cal, it's far more complicated than just one particular solution. So it's not enough to just say access is low, increase rates, or access is low, find more providers, or access is low, do something. And so, when we look at Illinois, Florida, New York, Texas has a different situation happening in it, but none of those states have great participation rates, and so we acknowledge that we could do better, but we're trying a bunch of different solutions because we're not convinced that one solution is the answer to the entire problem.
Thank you very much. Members, we open the floor for questions. Senator Money.
Thank you, Mr. Chair, and thank you, Ms. Kent and Ms. Cantwell. And my question, it predates your coming in as director, so this is not directed personally at you. But when I look at recommendation 8 to ensure Medi-Cal child beneficiaries have reasonable access to dental services, healthcare services should immediately resume performing its annual reimbursement rate reviews as state law requires. In your review of department policy, do you have any idea why it was determined not to conduct those annual reviews? And as head of the department, do you determine state laws that we pass to be optional?
No. So I think that's, it is one of those things that when there is a law in place that you have passed and that a governor has signed, the departments are bound to follow that until such time as the law is not changed. And so, again, in accepting and saying that all of these recommendations were fair, to the extent that the reports were not being done, and quite frankly, it doesn't matter what the reason was, it wasn't being done. And so, we are doing them, and these are the ones that are on track to be released in July. So I think that, again, the commitment is that we need to work with both you and stakeholders to be as transparent as possible. And so this is information that, is important for a lot of different reasons, to help you understand that we are either doing the job that we're supposed to be doing with the money that you have appropriated, or if we are not, then, we need to come and be accountable for that. So it's not a may, but it's a shall, and so we're going to get it done.
Well, I appreciate that, and I think that's what we need to hear, and I think there's an erosion of confidence, and one of the reasons for these oversight hearings is to make sure that there is not only transparency but accountability and responsibility, that we don't go through the exercise of passing laws just for the exercise, and that if there's I think one of our expectations would be is that if there's an internal reason of not being able to fulfill a responsibility, that we should be the first to be made aware of that, and that would be our expectation, I think, moving forward, and to work on a solution to understand why isn't it possible to meet that obligation, and what's the plan to meet the obligation, well before we need to resort to an auditor report.
Correct. Yeah, and that's totally fair, and we're committed to getting it done. But I think also sometimes verbal communication with the legislature and appropriate staff is something that just is, helpful and warranted. Obviously, if we're going to be late for a report, I would also take the same kind of, tact, which is there's something that's happened and there's a report that's due and we know it's anticipated, and if there's something that is holding it up in terms of, we have a data problem or something like that, I owe it, or someone from our, executive staff owes it to let you know that it's coming and we're working on it. So I commit to that.
Thank you. We appreciate that. Thank you, Mr. Chair.
Sure. We have, I believe, Councilmember Lee Thomas had a question and or comment.
Yeah, a couple of questions very quickly. What are the administration priorities for healthcare services? You said you have a list. Where does this rank in that list?
Wow. You're going to make all these other programs feel so challenged. So I really, there's maybe two or three. Dental's one of the three. The other one that is of significant note, it's both a point with pride and we still have more work to do, is the fact that we've enrolled 12 million individuals in the state of California. The problem is that we've enrolled 12 million individuals in the state of California with an immature IT system. And so I'm referring to our CalHERS IT system. That is immature, and it links into 3 county SAWS eligibility systems, and I am acutely aware that the workload and the burden that we put on eligibility workers on a county basis through this last year of just absolutely huge magnitude of change in the program was really hard, and there were a lot of workarounds. And so that's one of my other 2 big pending issues, is that there's still a lot of functionality that needs to be built in that system, because quite frankly for the workers that are sitting down in the county having to put these people through either an application or an annual redetermination, if the IT system isn't working, it sounds really administrative and kind of bureaucratic, but at the end of the day, if it doesn't work for that county eligibility worker, then it doesn't work for the beneficiary, which doesn't work for the program. So I see that as kind of one of my other top priorities. I didn't think I was going to be doing a lot of IT when I took the job, but sometimes the job
Large
dictates to you. So
that's what it is in the 21st century. Does the administration or your department have a perspective on school-based health centers as a part of our solutions with delivering these services?
Mm-hmm. I would say the school-based health centers provide a lot of valuable healthcare services to students of all ages, not just when it comes to dental care, but also to there's some mental health services and other screenings and other kinds of counseling and physical services that kids in schools need. We have traditionally worked with both the school-based health centers as well as clinics in general are kind of the backbone of many of the services that we provide. And so we see that as, just one more avenue by which, individuals in Medi-Cal can receive and access care. So sometimes if you don't live in a geographic area, where not necessarily in a rural area, but if you're in an urban area and you live in an area where there are no other providers, but there's a provider on a school-based health center, that's certainly appropriate, and we support that to the extent that we can.
All right, to the extent that we can. So resource allocation will be important in that dialogue. And I'm pleased that you seem to indicate that the administration is supportive. With respect to mailings, you mentioned, Ms. Cantwell. I don't know that we received, do you know if members of the legislature received notice about that mailing to beneficiaries? Because you may be aware in your experience that after they call you or whomever you contract with, they start calling us and local officials and local nonprofits and ask us various questions of which we may know not because it hasn't been disclosed. Do those disclosures come to members of the Health Committee, members of the legislature, and the like?